with Respitec, and she is going to be talking on airway clearance. So please welcome Danette.
Okay. Am I on? Can you guys hear me? No.
This one.
Oh. Not that one. Hold on. I thought I hit the button.
Okay, now speak.
How about now? We're all good? Okay. Perfect. Okay. Well, good afternoon. Lunch was good, wasn't it? Awesome. So no falling asleep. It was not a high-carb lunch. I saw that. So, well, my name is Danette Short. I am a registered respiratory therapist, and I am a certified asthma educator as well. I am the field clinical specialist. Is it the battery?
Okay, take that off.
Okay. Hold that thought.
Support at its best.
Okay, now you can hear me. So I am the field clinical specialist for the Midwest region for Respirtec. This is a lecture on airway clearance therapy. We are an airway clearance company. This will be a non-branded lecture. So I've told you I do work for Respirtec. We're an airway clearance company, non-branded. Fair enough? Okay. So today's agenda, we're going to look at the goals of airway clearance, review normal and abnormal airway clearance, overview of the respiratory tract and structure, hospital patient populations that require airway clearance therapy, airway clearance devices, and a look at the COPD population and the prevalence of bronchiectasis inside of that population. So the premise behind the premise behind airway clearance is that excess retained secretions are harmful, and that effective removal of pooled respiratory secretions can prevent episodes of acute pulmonary illness and prevent or delay progressive lung disease. We know this is true because we can look at our COPD patients. They are the ones who are swimming in the mucus, and when they have that mucus that settles in their lungs, they're more apt to come back for pneumonias, bronchitis, or even a COPD exacerbation. These are the patients we're looking for that need that help with airway clearance therapy. So the goal is that airway clearance is intended to impede mucus retention and to prevent or break the cycle of recurrent infection and progressive pulmonary deterioration. We know they deteriorate. If we look at a patient's PFTs prior to their exacerbation and then post-exacerbation, their FEV1 will not go back to what it was prior to the exacerbation. And with each subsequent exacerbation, they are going to lose lung volume. And we know that. So our whole goal is, how do we prevent these patients from having exacerbations or from doing more damage to their lungs? So airway clearance therapy is part of that, and making sure that we are helping these patients. We know with our lungs that time is tissue. The longer that an asthmatic patient has that inflammation inside their lungs, the more apt they are to have airway remodeling. And it's the same way with any of these other patients. The longer that mucus sits in there, the more likely it is to grow. And we don't want it to do that. When we talk about the pulmonary defense system, what we talk about, the first thing that we have to look is our cilia. We're going to find that through this a picture here of the pseudostratified columnar epithelial slide. Students, you've probably heard this in the last little bit. Us who've been out for, like me, a year, you're 7 or 8 years, yes. Okay, thank you. But you're like, pseudo what? It's a pseudostratified columnar epithelial slide. And so it looks at a portion of the lungs. And what you see across the top are our cilia. Here, these white tubular cells, those are our goblet cells. Our goblet cells secrete up to a cup of mucus a day in a healthy individual. Healthy individual. How many of those do we have coming into the hospital? None. So think of you, okay, I used to work NICU, and so they have really tiny suction catheters, so keep that in mind when I tell you this. I had a bad sinus infection, so bad that I was just like, can you please just suction me out? I've actually looked at a fellow RT, the one I trusted the most, As you heard, it wasn't a lot of you, it was the one. And it was just like, make me feel better. That, in my guesstimate, is how some of our patients live on a daily basis. They want the mucus gone, they can't get it gone, and they feel horrible because they have all that mucus. Now think of them when they get a cold. That's their worst. And these poor goblet cells, they're going to town because they're making so much mucus. So these are the patients that we're trying to help, is those who have all this extra mucus production. When we look at our cilia, we look at the fact that they beat in a whip-like fashion at 15 times per second. They live in this blue layer here, and it's called the sol layer. The sol layer is made up of 95% water and 5% solutes, like proteins, lipids, and minerals. That's what gives it its viscoelastic gel nature, you know, that gooey nature that SRTs like, that catches all the debris, and we can take it out when we cough. The problem comes is that when this sol layer becomes dried out, or when there's too much of the mucus and it starts laying down on top of those cilia, and the cilia can't move like they're supposed to. And then the other complication comes from a lot of these patients have a nicotine addiction, and nicotine numbs the cilia. So when the nicotine is numb, it's not moving in its whip-like fashion, it's just kind of there floating around. So we have to have the patient help themselves by, one, decreasing the nicotine, but also what can we do to keep that sol layer healthy? So we're going to keep talking about that. In a healthy individual, we're able to produce a mucus-clearing cough through a normal cough cycle. And there are 4 steps to a normal cough cycle. First, we have the irritation that enters the lungs. That irritation causes us to take a deep breath. With that deep breath, our epiglottis is open, and our diaphragm drops. As our epiglottis closes, our diaphragm will start coming up, and with a force, the diaphragm comes up, forcing the epiglottis open, and hopefully it is a debris-clearing cough. So that's what we want. Now, it's been a few years since I've had a patient in the hospital. Most of mine didn't do that. They were these little tiny baby coughs. So they really weren't clearing the mucus or clearing out what we needed them to clear out, are they? When we talk about abnormal airway clearance, there are 5 groupings of patients that we want to talk about. We have those who have retention of secretion problems. This will be more of our patients who have mucus plugging. We have our internal obstruction patients, so this is going to be more like our asthmatics and chronic bronchitis patients. External compression, you're going to see this with tumors, kyphoscoliosis, and pregnancy. Mucociliary dysfunction patients. This is our cystic fibrosis and our PCD, or primary ciliary dyskinesia patients. And then those with dry secretions. We are going to find them in any patient who has gone through surgery because the anesthesia dries them out. So that's where we're going to find our patients that we're looking for. Now, we have to do a little anatomy. Can't do this talk without some anatomy. It's funny is when, you guys will get a kick out of this, I do this for social workers and nurses as well, and I'm supposed to tell you that the bronchial tubes are in your lungs. So if some of you were confused about that, I want to know what school you went to. But, so we have our bronchial tubes, keeping in mind that your largest bronchial tube is the same size as your pinky, and that the smallest bronchial tube is that of 1 strand of hair around. So it's really tiny deep down in there. And when we're talking about our obstructed bronchioles, we're talking about our middle airways, okay? So we can see here that this is a nice, healthy lumen, and with a nice pink color. So when we talk about the pink color, it looks like a raw chicken breast. And that's the color we want to see inside of our lungs. Now up here, as you can see, the lumen is so much smaller, and it's redder, and now you got mucus in it. So when I do these talks for Better Breathers groups, one of the ways that I relate to them is I tell them, go to McDonald's, get your favorite drink. The normal bronchial tube is like drinking through that McDonald's straw, no problem, right? It's easy, it's one of the biggest straws in the fast food industry, and so they can drink it pretty easily. Now, take that same straw and go get a strawberry shake. It's going to take more work, more effort. It's taking more pull. And so they are going to get tired quicker. They're not going to drink for as long. They can get headaches. Now, for me, it's more brain freeze, but, for them, they get headaches because they're short of breath. So they kind of grasp that same concept of, okay, I get what you're saying. We know that working through all this airway clearance and all this, it's a vicious cycle. If we don't take care of the airway clearance issues, the mucus starts accumulating, we have obstructed airways, we have lung damage that occurs, the defense system is overwhelmed, and we still have not fixed the problem. And our whole goal is fixing the problem. So when we talk about how do we help these patients, which patients are we looking for? Well, inside the hospital, we're going to be looking for patients who have COPD, community-acquired pneumonias, and aspiration pneumonia as well. The mechanically ventilated patient, quadriplegia, paraplegia, or impaired mobility, post-op patients, various neuromotor and neuromuscular diseases, and then our bronchiectasis patients. Now, do you guys see a pattern here in these? The pattern would be patients who have limited mobility, and then patients who have respiratory issues are pretty much who we're looking for airway clearance issues. So we've done our anatomy, we've done our pre-stuff. Now what we're going to start doing is walking through the different forms of airway clearance, and we're going to start with the easiest and then move on up. Fair enough? So what we have first is incentive I know you guys have every one of us have handed out a magical little incentive spirometer device. They're magical because they grow legs. I can't tell you how many times I have gone in and set these up for these patients, and you go back to check on them because you're giving them a treatment, or maybe it's an O2 check or whatever, and you ask, have you been doing this every hour on the hour? Yes, I have. But the nurse just told you that she gave them something to help them with the pain and that they've been asleep for the last 4 hours. So the little device is over there in the window and it's doing its magic. That happens a lot because we did not remember to make sure that the patient understands that by them taking the deep breath, it will help keep their lungs cleared out, it'll help prevent the pneumonias, and it will help them get home sooner. Now, some of our patients probably don't want to hear the get home sooner part, so you might want to keep in mind which patients need to know that and which don't, because some of them like staying with us. So next we have our forced exhalation techniques. This is like huff coughing. This is a great technique to teach when the patient keeps telling you, I take a nap, I lay down, and I wake up with something right here, and I just can't get it up. Teach them huff coughing. They're not going to add it to their repertoire of their techniques for a little bit. But when they start noticing that every time they do the huff coughing and it works, it'll start being higher and higher on the list. Next is active cycle breathing techniques, such as breathing control, huff coughing, diaphragmatic breathing, and thoracic expansion exercises. Because this was asked at a recent lecture, no, we don't do them all at once. They are done individually for a short period of time, and you mix it up, okay? So if the patient likes doing breathing control more than they like doing the thoracic expansion, do a little bit more breathing control. It's all about working your lungs and moving and taking those breaths to be able to move the mucus out of the lungs. What I find is with these last two, that the patients who grasp these concepts of the like huff coughing and breathing techniques, they tend to go more to better breathers groups or work more with like rehab, pulmonary rehab. And they start talking to their buddies. And they see John walk in the door and he's not even short of breath, where they're like, see, I can't talk to you, I can't tell you my name, I can't do anything because I got to catch my breath. And they're just holding up a finger. Then they catch their breath and they're able to talk to you. Then they go over and sit down and they're back to being short of breath. But then they see John, and John's like strolling around the room and he's little Mr. Social, and he has the exact same thing that they do. And they start talking. And John goes, well, you know that respiratory therapist, they're not as crazy as they think they are. And we learned something from them. And that's where I see this, they hear us. They just don't know when to implement it. And by doing those two groups, they start implementing it a little quicker than those who don't. Next, autogenic drainage or manual chest physiotherapy. So autogenic drainage uses gravitation flow and diaphragmatic breathing and controlled coughing to mobilize secretions. Then we have the manual chest physiotherapy. So you can also have the postural drainage with that. Every one of us in here will do CPT differently because we're all different. The CPT that I perform at 7 in the morning is going to be different than I perform at 7 at night, especially if I